اوكي. هاي good evening everyone. انتوا سامعيني كويس؟ Can everybody hear me? Okay. I'll take this as a yes. So today we're going to be talking about the myocardial infarction from an ECG or an EKG point of view. These are the topics that we'll be discussing today. First, we'll be discussing the definition and classification of the myocardial infarction. We'll be discussing the ischemic changes that happens in the EKG. We'll be discussing the STEMI or the ST elevated myocardial infarction. We'll be discussing some differential diagnoses of ST elevation in the EKG, the non-ST elevated myocardial infarction, and the STEMI equivalent cases. First of all, before we begin, we should know a brief definition of myocardial infarction. So basically, myocardial infarction is the myocardial necrosis resulting from an obstruction of a coronary artery. So when a coronary artery is obstructed, it could cause the myocardial necrosis or ischemia that develops into necrosis and later on infarction. We have something called the fourth universal classification of MI, which classifies the MI into 5 different categories. The first category is due to the primary coronary event. For example, like a plaque rupture or a coronary dissection or erosion or ulceration of the coronary arteries. Type 2 is due to either an increase in oxygen demand, like cases of hypertension, or the decreased supply, like cases of hypotension, arrhythmias, brady or tachyarrhythmias, and embolism. We have type 3, and type 3 is related to sudden unexpected cardiac death. Now, type 4 and type 5 are intervention-based. So type 4, it is caused after PCI intervention, and type 5 is after coronary artery bypass grafting. So type 4 is subdivided into type 4A, and it occurs with PCI, and to diagnose it, we have to have an elevated cardiac troponin level of more than 5 times of the 99th percentile, while type B is related more to stent thrombosis. Type 5 is related to coronary artery bypass grafting, and we have to have an elevated cardiac troponin level of more than 10 times of 99th percentile. Now, when do we actually use the term myocardial infarction? To use the term myocardial infarction, we have to have some signs of the myocardial infarction. Like first, we have to have symptoms that represent myocardial ischemia. We have to have a rise in cardiac troponin of at least 1 value above the 99th percentile. We have to have new ischemic EKG changes and developmental of pathological Q waves. We have to have the imaging that supports the myocardial ischemia or infarction, like new loss of viable myocardium or new regional wall motion abnormalities. And we could also identify the actual coronary thrombus by coronary angio or autopsy post-mortem. Now, in these lectures, it is more of an EKG-based lectures. So this is why in this lecture, we'll be focusing more on the EKG changes that happens in myocardial ischemia or infarction. First of all, we need to classify the acute coronary syndromes into 3 main categories. We have the unstable angina. In the unstable angina, the patient might present with chest pain. You can find some EKG changes, but you're going to find negative cardiac biomarkers. The ST elevated myocardial infarction, you're going to find EKG changes and ST elevation, and we're going to have a positive cardiac biomarkers. And the non-STEMI or the non-ST elevated myocardial infarction, you can have an EKG changes such as ST segment depression or T-wave inversion, and we're going to also have a positive cardiac biomarkers. Now we've discussed the definition and classification of MI. Let's move on to the next point, which is the ischemic changes that happens in the EKG. First of all, in order to identify the ischemic changes that happens in the EKG, we need to have a look at the normal EKG. As we discussed in the previous lectures, and of course, the amazing introductory lecture by Dr. Iman, we know that the EKG is consisting of the P wave, the QRS complex, and the T wave. We have to identify a very important point in the EKG. This point is called the J point, because this point, we're going to measure from it the ST segment, either the elevation or depression, upon which we're going to be diagnosing the STEMI or the non-STEMI. Now, what happens in the EKG in the development of an MI? This is the baseline EKG that we have. A few minutes in the formation of the thrombus, we're going to have tall T waves. And then After minutes to hours, the ST segment begins to be elevated. So we'll have an ST elevation. Hours from the formation of the thrombus, we're going to have a persistent ST elevation. We're going to have a T wave inversion and a pathological Q wave that's starting to appear. And then after the resolution of the MI, the ST segment returns to normal, but there might be a T wave inversion. And of course, there's a Q wave in the EKG that denotes a previous myocardial infarction or ischemic event. We've discussed the definition classification of MI, the ischemic changes that happens in the EKG. Let's now move on to the actual topic. And first of all, we're going to be discussing the STEMI. So what is a STEMI? STEMI is defined by the European Society of Cardiology as, okay, so it's an ST elevated myocardial infarction. So of course, we're going to have an ST elevation in the EKG. Either this ST elevation from the J point is more than 2 millimeters in men or 1.5 millimeters in women, and that's in V2 and V3. This is considered a positive ST elevation or STEMI. Or in any other lead except V2 and V3, if there are at least 1 millimeter ST elevation, it has to be in two contiguous leads, and contiguous means that there are leads that share the same blood supply. So if we have an ST elevation of more than 1 millimeter in two contiguous leads, except for V2 and V3, then we say that this is a ST elevated myocardial infarction. In order for us to move to the EKG, first we have to know the leads that are distributed in the body and the affected area that it correlates and the culprit artery. Because what's very important in the EKG in diagnosing a myocardial infarction is that you can actually know the culprit artery that causes this kind of ischemia or infarction. So here we have the human heart. We have the coronary supplies of the heart. Here we have the right coronary artery and the left main coronary artery that's divided into LAD and LCX. And we have the corresponding EKG leads. So when we have an ST elevation from the corresponding EKG leads, it could tell us the affected area and also the artery that is the culprit of this ischemic changes. So here we have V1 and V2, which are the septal leads, and the culprit artery is the proximal LAD. Lead 3 and lead 4, it's the anterior, that's the affected area is the anterior area, and the arterial supply here is the LAD artery. In V5, V6, this is the lateral area of the heart, and the culprit is either the distal LAD artery or the LCX artery. We have lead 1 and AVL, which is the lateral. This is the affected area of the heart, is the lateral area of the heart, and the culprit artery is the LCX. We have lead 2, 3, and AVF, which is the inferior. It corresponds to the inferior area of the heart. And of course, the culprit artery here will be 90% of the time the right coronary artery, and 10% of the time it could be the LCX. Now we have something called a posterior MI, and we're going to be discussing it in more details later on. And in this posterior MI, we're going to notice the ST segment elevation or changes in V7, V8, and V9, which is a posterior EKG, and we will be discussing it later on. There's something called reciprocal changes that happens in the EKG. So basically, when you have an ST elevation, at some point, you're going to have a reciprocal ST depression at the other corresponding leads. So if we have an anterior anteroseptal myocardial infarction, then the reciprocal changes are going to be happening in the inferior leads, lead 2, 3, and AVF. And on the other hand, if we have an inferior myocardial infarction, you're going to see reciprocal changes in lead 1 and AVL. And from its name, the posterior myocardial infarction, we're going to have reciprocal changes as the depression in the anterior leads. And this is what raises the suspicion of a posterior MI, as we're going to be discussing later on. Here we have the famous picture of simplified picture of the EKG to know the leads. So lead 1, AVL, V5, and V6 are the lateral leads. V1 and V2 are the septal leads. V3, 4 anterior leads. And the inferior is 2, 3, and AVF. So we have some EKG examples here. Here we can find, okay, this could be the interaction part, so people could join if they want. But I know that's too simple for you guys. So here we can have, this ECG shows elevation in V2, V3, V4, V5. So, and V6, that's the anterolateral leads, and it also has an elevation in lead 1 and AVL. So this is the anterolateral STEMI. Here's another EKG. As you can see, we can notice an ST elevation in V2, V3, V4, and AVL as well, and lead 1. So this is also an anterolateral STEMI. Here we have an ST elevation in lead 1 and in AVL, and a corresponding ST depression in the inferior leads. So this is a lateral STEMI. And here we have an ST elevation in lead 2, lead 3, and AVL. So this is an inferior STEMI. Now we will be discussing something called an extensive anterior MI. So basically, extensive anterior MI, from its name, it's a massive ST elevation, and it has a specific morphology. It's called a tombstone morphology. As you can see in this picture, it literally looks like this. And when we see the tombstone morphology, it indicates that there is an infarction in the proximal LAD or LAD occlusion, and it has and it denotes that we have a very poor LV systolic function, which also increases the likelihood of cardiogenic shock and death. Actually, mortality in these cases happen in 35% of the time. So this is a very distinctive tombstone appearance in the EKG of the extensive anterior MI. We will also be discussing the RV infarction. So basically, the RV infarction, in order to recognize it, you see an EKG and you see there are an ST elevation in the inferior leads, the lead 2, lead 3, and AVF. After you see that you have an inferior STEMI, you could look for lead V1 and V2. If you can find an ST elevation in V1 or an ST elevation in V1 and depression in V2, and that's very highly specific for RV infarction, or you could even find an isoelectric ST segment in V1 with marked ST depression in V2, and the ST elevation in lead 3 has to be more than the elevation in lead 2. These are all signs suggestive of RV infarction. But in order to actually diagnose the RV infarction, we have to do what's called a right-sided EKG, which is basically replacing the EKG leads at the right side of the chest in a mirror image way. Of course, when we're looking at the EKG, V4 or V4, the right-sided EKG, it's considered that has sensitivity of 83% and accuracy of 88% in the diagnosis of RV infarction. So it's a very important lead to look at. Okay, here we have an example. If we're looking at the EKG at first, we're going to see an ST elevation in lead 2, 3, and AVF. And if we move on to V1, you can see the isoelectric line in V1. And you can see the ST depression in V2, or the extensive ST depression in V2. So these are all signs of the RV infarction. Here we have another example. We also have lead 2, 3, AVF, and you can find an ST elevation in V1, and the ST elevation in V3 is more than the ST elevation in V2. So this also is suggestive of an RV infarction. Okay, so we've discussed the different kinds of STEMI, and we've discussed also the extensive anterior STEMI and the RV infarction. Now we're going to be talking about a posterior STEMI. We've mentioned this before. The posterior STEMI, in order to raise the suspicion of a posterior STEMI, you're going to have an ST depression in the anterior leads, which are the reciprocal changes that happens. So when you find ST depression in the anterior leads, prominent R waves in V2 and V3 and upright anterior T waves, it raises the suspicion of a posterior STEMI. So what can we do now? We should do a posterior EKG. So basically, the posterior EKG, we're going to put lead V7, V8, and V9. V7 is going to be placed at the level of V6 in the posterior axillary line. V8 is going to be placed at the tip of the scapula, and V9 is going to be in the pars spinous region. They're all on the same level. There's an EKG example of a posterior STEMI. Here we have an ST segment depression in the anterior leads. So we did a posterior EKG, and we have V7, V8, and V9. And as you can see, there's marked ST elevation in these leads. So this is the posterior STEMI. So we've discussed so far the definition and classification of myocardial infarction. We've discussed the ischemic changes that happens in the EKG. We've discussed the STEMI. Now we're going to just mention some differential diagnoses of ST elevation in the EKG. I'm not going to explain each one of them, but we should keep in mind and we should know that there could be a non-MI related ST elevation found on the EKG. Like in cases, of course, of the STEMI, that's differential diagnosis of ST segment elevation. So of course, in the STEMI, pericarditis, which we see a lot in our ICU, left bundle branch block, LVH, ventricular aneurysm, coronary vasospasm, which is pain mediated. You can find an ST elevation during the pain episode of people with Prince metal angina and hyperkalemia. Now I'm going to be just giving a bit of an account on the pericarditis because we see a lot of people with pericarditis post-op in our ICU. So we should know how to diagnose the pericarditis from an EKG. So to diagnose a pericarditis, you have to find a diffuse elevation of the ST segment. Usually it's in a concave manner, as we're going to see. And you can find an ST depression in the P and PR elevation in AVR and V1, and this is called a knuckle sign. Here we have an EKG, and as we can see, there is diffuse elevation of the ST segment all throughout the EKG. And when we look at V1 and AVR, we can find there is a PR elevation in AVR and V1, and there's also an ST depression in AVR and V1. So this is pericarditis, and it's not STEMI. So we've discussed definition and the classification of the myocardial infarction, ischemic changes in EKG. We discussed STEMI and some differential diagnoses of the ST elevation in EKG. Now we're going to be talking a bit about the non-ST elevated acute coronary syndromes. The non-ST elevated acute coronary syndromes, we've mentioned them at the start of the lecture, and there are two types mainly. There's an unstable angina and there's a non-STEMI. They share something in common, which is you can find EKG changes in both of them. But in unstable angina, you're going to have negative cardiac enzymes, and in the non-STEMI, you're going to have a positive cardiac enzymes. So we will be talking now, because this is an EKG-based lecture, we're going to be talking about some of the EKG changes that are going to appear in cases of non-STEMI. So the EKG changes that will appear is either related to the ST segment or the T wave. So the ST segment, there has to be ST segment depression in the EKG. It could be upsloping, it could be downsloping, or it could be horizontal. And it has, as we said in the STEMI, the elevation has to be more than 1 millimeter, okay? But here in the ST depression, it could be as little as 0.5 millimeter at the J point. That is a significant ST depression. And of course, the more extensive the depression, the worse prognosis that this patient has. And they found that when there's an ST depression of more than 2 millimeters in more than 3 years, 3 leads, this is associated with a high probability of mortality. So here we have an EKG, and as we can see, there is a diffuse ST segment depression all throughout the EKG. And the ST segment depression, it denotes that there is a subendocardial ischemia, and it is widespread. They're present in most of the leads of the EKG. And if we have this pattern, then we should look at the AVR lead, because if we can find an ST elevation of more than 1 millimeter in the AVR lead, then this is highly suggestive of a left main coronary artery occlusion, and we're going to be talking about that later on. Now, what changes happens in the T wave? So the T wave, as we've discussed again at the start of the lecture, from the ischemic changes, the T wave becomes inverted. So if we have a T wave inversion of at least 1 millimeter deep, and it's present in 2 contiguous leads that have a dominant R wave, and they're dynamic, which means that they are not present in any previous EKG, then we say that this is a significant T wave inversion. As we can see here in this EKG, we have T wave inversion in V5 and V6. So this denotes that this person has some ischemic episode. Before we move on, I'd like to just mention something called Wellen syndrome. So what is Wellen syndrome? It's a clinical syndrome. Well, there's this doctor, there's this scientist. He was called Swan, I think, Swan Wellen, and he noticed that there is a pattern of the T wave in the EKG of people who develop later on acute anterior myocardial infarction. And this pattern could go one of two ways. It could have in V2 and V3. It could be type A or biphasic T wave, like this example, or it could be type B or deeply inverted T wave. And when we see this pattern and we suspect Wellen syndrome, so as a clinician, I put in my mind that this is very highly specific for critical stenosis of LAD, and this patient actually needs PCI, or else he will develop acute anterior myocardial infarction. Okay, so we've discussed the definition and the classification of MI, ischemic changes that happens in the EKG, the ST elevated myocardial infarction, some differential diagnoses of the ST elevation in the EKG, and the non-ST elevated acute coronary syndromes. Now we're going to be discussing three little topics. They are STEMI equivalent. So this is a person who has an ischemic event and there are no ST elevation in his EKG, yet they are considered STEMI equivalent and they should be treated and managed the same way. The three things that we're going to be discussing is the left main equivalent, acute left bundle branch block, and the Winter syndrome. So in the left main equivalent, we've given a hint on it when we were discussing the non-ST elevated acute coronary syndromes, and we said that if we can find widespread ST segment depression, we should look at AVR and V1. If we find an ST segment elevation in AVR and AV1, then this is highly suggestive of occlusion of the left main coronary artery. Like in these EKGs, as we can see, there is diffuse ST segment depression all throughout the EKG, and we find ST elevation in AVR and V1. Here is another example. There's a diffuse ST depression as well, and we're looking at AVR and V1, and we can find an ST segment elevation. Is the left main occlusion actually a misnomer? Well, ST elevation in AVR with coexistent multi-lead ST depression, it only indicates subintracardial ischemia due to an oxygen supply demand mismatch. So either the supply is low, or we have a decreased supply of oxygen, or increased demand, as we mentioned at the start of the lecture, and this is called the subintracardial ischemia, which appears in the EKG as multi-lead ST depression. But is the left main coronary artery the main culprit? That is wrong, because it could mean that there is a left main coronary artery stenosis, of course. It could mean that there is a proximal left anterior descending artery stenosis. It could mean that the patient has severe multivessel disease, or he could have hypoxia or hypotension. All of these things are going to be causing an O2 supply and demand mismatch, which would later lead on to this specific pattern on the EKG. Now we're going to be discussing De Winter syndrome. So to diagnose a De Winter syndrome, you have to have a tall, prominent symmetrical T waves in the precordial leads, and you have to have an upsloping ST segment depression of more than 1 millimeter at the J point in the precordial leads. You're going to have reciprocal ST segment elevation 0.5 or 1 millimeter in AVR. And what is the clinical significance of this is if we see this pattern on the EKG, it was found that in 2% of the patient, it means there is a LAD occlusion, which is equivalent to the anterior STEMI. So again, this is treated like STEMI. And if we can find this pattern on the EKG, then we have to manage this person or this patient urgently. Here we can see in the EKG, there is an upsloping ST segment depression of more than 1 millimeter. And this is the pattern on the EKG. We have some examples here. Sorry. So here we have the tall T waves in the precordial leads. We have an upsloping ST segment depression, and we have 1 millimeter of ST segment elevation in AVR. Here's another example. Again, the tall prominent T waves, the upsloping ST depression in the precordial leads, and the ST elevation in the AVR. The final thing that we're going to be discussing in the STEMI equivalent cases is the left bundle branch block. So we will be discussing left bundle branch block later on in more detail, but what is important for me right now is diagnosing the acute or the new left bundle branch block, because it is, again, equivalent to STEMI, and the management of the acute left bundle branch block should be considered as the same management of the STEMI patients. But how do I know if this left bundle branch block acute or new or not? We have something called the Scarboza criteria. And the Scarboza criteria, it is 3 criteria. So you can either find a concordant, it's a point system, basically it's a point system, and each criteria takes a certain amount of points. And if you have more than or equal to 3 points, then you can say that this is a new or acute left bundle branch block. These criteria include a concordant ST elevation of more than 1 millimeter in leads with a positive QRS, which basically means that concordant means it goes the same way as lead. So if the lead is positive and you have an ST elevation, we call this a concordant ST elevation, and it has to be more than 1 millimeter. Of course, in the left bundle branch block, the leads that have a positive QRS are V4 to V6, AVL, or lead 1. Or you can find a concordant ST depression of more than 1 millimeter in V1 to V3, and this takes 3 points. Or you can find an excessively discordant ST elevation of more than 5 millimeters in lead with a negative QRS complex, and this takes only 2 points. Here is a picture to better understand the Scarboza criteria. So basically here we have a concordant ST elevation in the leads with a positive QRS complex. We have a concordant ST depression within the leads that have negative QRS complex. And here we have a discordant ST elevation of more than 5 millimeter in the leads with negative QRS complex. And as I mentioned before, the score more than or equal to 3 is highly suggestive of acute left bundle branch. Now we have another scientist called Smith, who modified this criteria a bit. Basically, there's the same criteria, but he just modified the last one or the third one to be more accurate. So basically, he said, instead of saying that we have a discordant ST elevation of more than 5 millimeters, he says that if the ST elevation is more than 25% for the preceding S wave, then this is considered a positive Scarboza criteria or Smith modified Scarboza criteria. Now we have some EKG examples of the acute left bundle branch block. So this is an EKG of left bundle branch block. Now I need to know if this is an acute one or if this is an old one. And as we can see in V2 through V5, there is a concordant ST depression. So this takes 3 points. Here's another example. Here we have a left bundle branch block, and if we're looking at AVL, we're going to find a concordant ST elevation of 1 millimeter, and this takes 5 points. To recap, we've discussed the definition and classification of the myocardial infarction. We have discussed the ischemic changes that happens in the EKG when a person developing myocardial ischemia or infarction. We've discussed the ST elevated myocardial infarction, some differential diagnoses of ST elevation in EKG, the non-ST elevated myocardial infarction, and the STEMI equivalent cases. That's it for today. I'll see you next time, and thank you.
شكرا جزيلا يا دكتورة أمنية. محاضرة ممتازة.
شكرا يا دكتورة أمنية، محاضرة ممتعة للي بيحبوا الإنجليزي واللي بيحبوا الاثنين مع بعض.
شكرا يا شيخ. احنا المفروض ان احنا معانا I think we have guests from Oxford. This is why this lecture was English based so that they can ما اعرفش هم جم ولا لا، بس يعني we invited them so this is why.
المحاضرة بالإنجليزي وقالت لك يعني explain بتاعها بالإنجليزي برضه.
ما عشان هم يفهموا عشان ما يحسوش ان هم left out بس. ماشي شكرا يا شباب. يلا باي باي يا شباب. امشي.